Thank you for giving me the opportunity to present to you this study about Iptacopan, which is a complement inhibitor of factor B in patients with paroxysmal nocturnal hemoglobinuria, so-called PNH. So I'm Régis Beffaud-Leto, I'm the head of the French Reference Center for Aplastic Anemia and PNH. So PNH is a rare hematological disorder that's characterized by intravascular hemolysis, thrombosis, and bone marrow failure. Basically, this disease is due to a somatic mutation, big A gene, resulting from a lack of GPI-encoded complement regulating proteins called CD55 and CD59. As you can see here, the complement cascade, which is permanently activated, is leading to intravascular hemolysis in PNH because of those regulators that are not present. C5 inhibitors, eculizumab, has been developed 15 years ago, and more recently, ravulizumab, target the terminal complement pathway, controlling intravascular hemolysis, reducing thrombosis, and eventually improving overall survival. However, C5 inhibition do not avoid the early activation, the complement cascade, and the C3 deposition at the cell surface, which is associated with a extravascular hemolysis, which is mediated by macrophages in the liver and the spleen. That's the reason why 2/3 of the patients are still anemic under standard of care, with some of them being regularly transfused. Iptacopan is the first-in-class oral factor B inhibitor that target the complement at the proximal level. So as you can see here, Iptacopan is able to bind the active site of factor B, inhibiting the activity of the C3 convertase, and as a consequence, inhibiting the C3 opsonizations, and thus this vascular hemolysis. It has been recently published in the phase 2 studies that in 10 patients who were still transfused, all transfused under eculizumab, Iptacopan was able to control intravascular and extravascular hemolysis, all patients becoming transfusion independent. That was a rationale of the present study. This study is called APPLY. This is a phase 3 study targeting adult patients with PNH and clinically significant extravascular hemolysis. As you can see, patients were randomized 8-5 to receive oral Iptacopan for 24 weeks or standard of care eculizumab or ravulizumab. And then they were all entering in an extension phase, receiving whole oral Iptacopan. There was 2 primary endpoints for that study. The first one was hematological response, defined as an increase from baseline in hemoglobin level of 2 grams per deciliter or more in the absence of transfusion. The second one was hematological response, defined as the proportion of patients reaching 12 grams hemoglobin or more in the absence of red blood cells transfusions. The other endpoints were quite classical in PNH. So they are the primary endpoint. As you can see, there was 51 of 60 patients in the Iptacopan arm who presented an increase from baseline hemoglobin level of 2 grams per deciliter or more in the absence of transfusion versus no patients in the standard of care. Using pre-specified statistical analysis showed a huge differences between treatment in favor of Iptacopan. Looking for the proportion of patients who reach hemoglobin level 12 grams per deciliter or more in the absence of red blood cell transfusion, were about 42 out of 60 patients in Iptacopan arm versus no patients standard of care. Again, a big difference between both treatment in favor of Iptacopan. What about the other endpoints? As you can see here, Iptacopan was also superior to standard of care for transfusion avoidance. And here you can see that there was a mean hemoglobin average differences adjusted about 3.63 grams per deciliter between baseline and 24 weeks in favor of Iptacopan. Briefly, the other endpoints, you can see there was a drastic reduction in reticulocyte counts in patients with Iptacopan, showing a good control of extravascular hemolysis. However, LDH were the same than in standard of care, showing that Iptacopan was also able to maintain the control of intravascular hemolysis the same way as standard of care. In terms of breakthrough hemolysis, there was less events in the Iptacopan group. There was one major adverse vascular event in the entire study. There was a transient ischemic attack in the patients who were under Iptacopan, but this event was not related to Iptacopan by the principal investigators. If not, the patients presented a concomitant sick sinus syndrome that might explain these episodes. The patient is still under Iptacopan 9 months after and is doing very well. And as you can see here, the safety profile of the drug was excellent. So in conclusion, this study demonstrates Iptacopan to be superior to standard of care by reaching both primary endpoint significance. Many patients achieve clinically meaningful increase in hemoglobin level, and higher proportion of patients increase 12 grams per deciliter hemoglobin or more. This leads to high rates of patients transfusion independent and reduced patients reported fatigue eventually. As shown here, Iptacopan was not only able to control intravascular hemolysis, but also extravascular hemolysis in those patients, and it was well tolerated with no serious hemolysis during the 24 weeks. However, single-agent Iptacopan may now represent a practice-changing oral outpatient treatment for patients with PNH who are suboptimal responders to eculizumab or avelizumab. And in the end, we may think that it might become a preferred treatment options for all patients with hemolytic PNH. Thank you for your attention.